So let us talk about neonatal chest X-ray and try to solve it in a systemic way. I know this is a busy spot, but I think this is the simplest way to do that. Now let us see what is the differential diagnosis of increased opacity in neonatal chest radiograph. So first we have respiratory distress syndrome, RDS. We have transient tachypnea of newborn, meconium aspiration, and neonatal pneumonia. And lastly, we have pulmonary interstitial emphysema and bronchopulmonary dysplasia, which are complications of RDS and oxygen therapy. So we can differentiate between them by two things: neonatal history and second, the radiological findings. So let us talk about the history. First, in respiratory distress syndrome usually occur in premature baby. And how we know this is premature? By the absence of humeral head, and the child will have small tiny chests, and we can compare it with the ECG leads. Third, the presence of umbilical catheters, which are ideally removed within 10 days to weeks after birth. The second, transient tachypnea of newborn, and usually occur in neonate who has born by cesarean section. The meconium aspiration, the child usually is post-term. Neonatal pneumonia usually occur in premature rupture of membrane with elevated inflammatory markers. The pulmonary interstitial emphysema and the bronchopulmonary dysplasia are presented late because, as we said, they are a complication of RDS and oxygen therapy. Now let us talk about the radiological findings of each. So the RDS, usually the chest is small and there is a reduction in lung volume. There is bilateral symmetrical diffuse granularity. We can see also some air bronchogram, and usually there is no pleural effusion. Transient tachypnea of newborn appear as reticular hilar opacity, as we can see here. And maybe there is some pleural effusion. Because the transient tachypnea of newborn is a simply volume overload, just like pulmonary edema, due to squeeze that occur in cesarean section, the change usually transient and resolve within 2 to 3 days. In meconium aspiration, usually there is dense band opacities that extend from the hilum toward the periphery of the lung, as you can see here. You can see left side. The neonatal pneumonia usually presents as patchy consolidation and usually unilateral. Pulmonary interstitial emphysema usually occur in a child with RDS. So usually there is background of granularity, as we can see in this right lung. But instead of small volume, the lung looks overexpanded. And as we can see here, it's even bulged through the intercostal space with flattening of hemidiaphragm. Then the air starts to leak through the interstitium, forming those linear lucencies that radiating from the hilum. And even the air can leak to pleural space. As we can see here, we have small right basal pneumothorax. Bronchopulmonary dysplasia, it's a late stage of fibrosis and cystic change. And here the lucencies are not linear but rounded, giving the lungs of bubbly appearance. So in conclusion, the differentiation is first by presentation and second radiological findings. RDS will be bilateral diffuse granularity. Transient tachypnea of newborn appear as bilateral reticular opacities. Meconium aspiration, usually there is dense band-like opacities that extend from the hilum toward the periphery. Pulmonary interstitial emphysema appear as linear lucencies that extend from the hilum in a background of granularity. Bronchopulmonary dysplasia, it's a cystic lung. And finally, the pneumonia is usually patchy and usually unilateral. Finally, let us look for some complication of RDS and oxygen therapy. So I prefer first to look for tube and lines, and then look for air leak elsewhere in the chest or abdomen, and look for any pneumothorax, pneumopericardium, pneumomediastinum, or pneumoperitoneum. So let us see this first case. Let us check the tubes and lines. So we have endotracheal tube, we have orogastric tube, and umbilical artery catheter. All are in proper position. The umbilical venous catheter is a little bit down. They need to up a little bit. Now we have bilateral diffuse granular opacities. In a child looks like premature. There is no humeral heads. So this is typical case of RDS. When we look on the abdomen, we can see this lucencies over the liver. So this is football sign of pneumoperitoneum as well as falciform ligament sign. So this is an RDS with pneumoperitoneum. The second case, let us check the tubes and lines. So the endotracheal tube in situ, orogastric tube a little bit high. We can see the hole, it's still in the esophagus, so they need to push it down a little bit. The umbilical venous catheter is up, need to be pulled down a little bit. There is sign of prematurity, no humeral heads. There is tiny chest, small lungs, bilateral diffuse granularity. There is also some linear lucencies. So this could be a sign of pulmonary interstitial emphysema, and the air leak to the left pleural space. We can see that mediastinum is shifted to the right side. There is depressed left hemidiaphragm. So this is a case of RDS, start to develop pulmonary interstitial emphysema and tension left pneumothorax. The third case, again, this is premature baby. We can see that no humeral heads, small chest, bilateral diffuse granularity. We can see there is distended bowel loops, and there is linear opacities in the right iliac fossa, representing pneumatosis intestinalis. Also, there is air over the liver shadow. So this is football sign, falciform ligament sign of pneumoperitoneum. So this is a premature child with necrotizing enterocolitis and complicated pneumoperitoneum. And this was the last case. Thank you for watching, and I hope this was helpful.